Bismillahir Rahmanir Rahim. I am Dr. Ali Asghar, consultant endocrinologist from the port city of Karachi, and a very warm welcome to this Pakistan Endocrine Society course on thyroid disorders. I'll be telling you all about how to approach a patient with hyperthyroidism. So what is hyperthyroidism? It's simply overactivity of the thyroid gland, leading to excessive synthesis of the thyroid hormones, which in return increases the metabolism in the peripheral tissues of the human body. Difference between thyrotoxicosis and hyperthyroidism. Many people use these terms interchangeably, but there is a difference. Thyrotoxicosis is basically the clinical spectrum of hyperthyroidism. It's basically the clinical syndrome resulting from increased thyroid hormone synthesis and increased metabolism. With medications, we can actually control thyrotoxicosis, although there still may be hyperthyroidism. Hyperthyroidism simply means overactivity of the thyroid gland, which leads to thyrotoxicosis. So thyrotoxicosis is the clinical spectrum, and hyperthyroidism is the basic illness in which there is increased thyroid hormones. What are the causes of hyperthyroidism? So this is a long list of causes of hyperthyroidism. Graves' disease, where there is diffuse toxic goiter. So when I say toxic, it's not how humans can be toxic. It's thyroid which is toxic. So toxic means producing more thyroid hormone. So Graves' disease, diffuse toxic goiter. Then Plummer's disease, toxic multinodular goiter. Toxic phase of subacute thyroiditis. Toxic single adenoma. Pituitary tumors like TSHoma, molar pregnancy and choriocarcinoma, where there is increased beta-HCG, metastatic thyroid cancers, struma ovariae, dermoid and ovarian tumors, and then thyrotoxicosis factitia, when a patient actually creates an artificial hyperthyroidism, artificial thyrotoxicosis basically, and then medications like amiodarone and SSRIs. So these are the common causes of hyperthyroidism. In more than 95% of cases, these are the causes. Graves' disease, where there is diffuse toxic goiter, Plummer's disease, where there is toxic multinodular goiter, toxic phase of subacute thyroiditis, and toxic single adenoma. So let's move on to case history. So we have got 7 interesting cases for you. This is case history number 1. 32-year-old medical doctor. Now consider yourself as if you're sitting in the clinics, right? So 32-year-old medical doctor presented with 1-year history of weight loss, 7 kilogram, palpitations, heat intolerance, tremors, scanty but regular menses. So what is going on? I know you're all thinking about hyperthyroidism because that is where the lecture is. So it's easy to point out that this might be hyperthyroidism, but in these case histories, we'll go through different causes of hyperthyroidism as well. So again, the height is 160 centimeters, weight is 47 kilogram, body mass index is 18.3 on the lower edge, blood pressure 120/70, pulse is 100 per minute, almost tachycardic, bilateral proptosis, right more than left with lid lag. Thyroid has got grade 2 diffuse goiter. There is also bruit on examination, tremors in both the hands, moist and warm palms. The lab data suggest an FT4 of 3.3, which is more than the range. The range is up to 1.9, so increased FT4. And then TSH, which is low, 0.02. The range is 0.4 to 4.0. So a low TSH, a high FT4, thyroid antibodies is positive. Now, many of the symptoms here, which is weight loss, palpitations, heat intolerance, and again, a low BMI, tachycardia, proptosis, tremors, antibody positive, Bruy positive. So you all understand that yes, there is hyperthyroidism. So what is the diagnosis? Of course, hyperthyroidism, but in hyperthyroidism, what is the cause of this particular hyperthyroidism? Now, going back onto the case, look at this. See, in hyperthyroidism, there are a lot of features, but there are pertinent symptoms and signs from which you can ascertain what is the real reason of this particular hyperthyroidism. Now, going back to the case, if you see, there is proptosis. Again, there is Bruy present. Again, there is thyroid antibodies which are positive. And all this points towards Graves' disease. So what should be the treatment plan? Now, in Graves' disease, you can either give anti-thyroid medications or radioactive iodine, and we'll discuss this further as we go forward. So patient decides in favor of anti-thyroid drug therapy. Now, there are certain questions about anti-thyroid drug therapy. Which drug should be used to treat this patient? Propylthiouracil or carbimazole? Now, remember, carbimazole or methimazole is the drug of choice in terms of anti-thyroid medications to treat Graves' disease. But in pregnancy, in the first 3 months of pregnancy, which is the first trimester of pregnancy, carbimazole or methimazole should not be given. Rather, we should be using propylthiouracil, PTU. Likewise, any female who's in the reproductive age group, she's married, she wants to conceive, again, start her on propylthiouracil, because when she conceives, she doesn't know that she has conceived. There are a few weeks which already may have passed, and carbimazole and methimazole can be detrimental for the fetus. So again, propylthiouracil is only used in the first 3 months of pregnancy. That's the only indication. Again, somebody who's allergic to carbimazole or methimazole should be switched over to PTU, propylthiouracil. But again, the allergic reaction, there is cross reaction. So somebody allergic to carbimazole or methimazole most likely might also be allergic to propylthiouracil as well. So the drug of choice, apart from pregnancy's first 3 months, is always carbimazole or methimazole. For how long should be treated to optimize chances of remission? Now, it is said that in 18 months' time, 50% of these patients, they go into remission. But those that go into remission, in the next 1 year, 40% of them will have a relapse of the disease. So does the drug influence chances of remission? What dose should be used initially to get a disease under control? Yes, of course, when you treat with anti-thyroid medication, you give a better chance for Graves' disease to go into remission. Then it may automatically go into remission as well, but medications will help us to achieve that remission in due course in time. Again, what dose to start? So unlike thyroxine, where you start with the lower dose and go up, with carbimazole or methimazole, you start with a high dose and go low. So you usually start with 30 milligram to 40 milligram per day. The carbimazole tablet available in Pakistan is 5 milligram. So usually we start with 3 tablets in the morning and 3 tablets in the night. And in some patients, we also have to start with 40 milligram. So we give 40 milligram in divided doses in 24 hours. Would the co-administration of T4 during thyroid drug therapy block and replace enhancer chances of remission? So there was a method known as block and replace regimen, still practiced in UK, but very common in olden times, but not now. So what they used to do was they used to give full dose of carbimazole, 40 to 60 milligram, keep it blocked, and then as the patient becomes hypothyroid because of this blockage, they used to give thyroxine. In all this treatment, they used to keep the carbimazole dose at the highest dose, continue with the highest dose, and as the patient becomes hypothyroid, they used to start thyroxine together with carbimazole at the highest dose. This is no more practiced in the modern world. or not practiced in most of the modern world. In most of the modern world, you start with a high dose of carbimazole, and then as the results get better, or starts to get better, you start tapering down the carbimazole dose. Question number 5, is this patient a good candidate for primary antithyroid therapy, or is she unlikely to achieve a remission, making RAI 131 a better initial choice? It's always a big debate, antithyroid therapy versus RAI therapy in Graves' disease. So usually we start with antithyroid medications, and once the patient is close to becoming euthyroid, you have an option to either continue with antithyroid medications or go on and give radioactive iodine. This is a big debate. The usual conventional practice is to continue with antithyroid medications and see the response. And if the patient doesn't have a good response, you always have an option of moving towards radioactive iodine. So Graves' disease is the most common cause of thyrotoxicosis. 50% of thyrotoxicosis is Graves' disease. Organ-specific autoimmune disease. And then again, you have got autoantibodies that can be seen in the blood, like thyroid-stimulating immunoglobulin or the TSH receptor antibodies, which are now being checked in Pakistan as well. Again, Graves' disease might have antibodies related to hypothyroidism, like anti-thyroid peroxidase or anti-thyroglobulin antibody or antimicrosomal antibodies. And because it is an autoimmune disease, there might be other autoimmune diseases linked to it, like pernicious anemia, type 1 diabetes mellitus, rheumatoid arthritis, myasthenia, vitiligo, and adrenaline insufficiency. So as somebody who's treating Graves' disease, we need to keep our eyes open to keep a watch for these anti-autoimmune diseases as well. Now, this is a technetium scan, thyroid technetium scan. Remember, there is usually no role of an ultrasound scan in hyperthyroidism. What we need in hyperthyroidism is a thyroid technetium scan, which is done from usually big tertiary care setups across the city and the country. So this is a normal scan. You can see the two wings of the butterfly on the left side of your screen. Here is the one left lobe, and here is the right lobe. And then in Graves' disease, there is increased uptake in both the lobes, and there is diffusely increased uptake in both the lobes. So when you do a technetium scan in Graves' disease, you see the two lobes of the thyroid gland very clearly, which has got increased uptake. So this was Graves' disease. Remember, 50% of your hyperthyroidism is Graves' disease. Let's move on to case history number 2. This is a 40-year-old lady with 10 years history of non-toxic multinodular goiter. So she had multinodular goiter present, which was non-toxic. Toxic means making more thyroid hormone. So this was not making more thyroid hormone. So 40-year-old lady, 10-year history of non-toxic multinodular goiter, presented to gynecology clinic with irregular menses, anxiety, palpitation, fatigue, and weight loss. BMI is 29, she's obese, blood pressure is normal, pulse is 126, she's tachycardic, blood pressure, temperature is 36.8, which is okay. Thyroid has got grade 2 multinodular goiter. There is no bruit, no proptosis, mild lid lag. Remember that lid lag and lid retraction are there in thyrotoxicosis. Because of any reason of hyperthyroidism, if there are more thyroid hormones, there is thyrotoxicosis, you can see lid lag and lid retraction. Again, fine tremors, moist and warm palms, FT4 2.19, which is high, TSH 0.019, which is low, thyroid antibodies is negative. You do a technetium scan, there are 2 hot nodules. Hot means picking up the technetium more. So hot nodules with poor uptake in the rest of the nodules. What is the diagnosis? What is the best treatment plan? Now remember, this is a multinodular goiter, initially non-toxic. Now there is anxiety, palpitation, weight loss, tachycardia. There is no bruit, no apoptosis. You see lid lag and tremors, which is thyrotoxicosis. You see moist and warm palms. Again, FT4 is high, TSH is low, antibodies are negative. What is the diagnosis? Yes, toxic multinodular goiter. Now, a multinodular goiter, where there are many nodules, can be euthyroid, means non-toxic, or this can be toxic, producing more thyroid hormones. What is the best treatment plan? So the best treatment plan is radioactive iodine ablation. So unlike Graves' disease, toxic multinodular goiter will not go into remission on its own in most cases. And either you have to continue carbimazole or methimazole for a long time, or you consider giving radioactive iodine therapy once the thyroid hormones are close to the normal range. Remember, whenever we give radioactive iodine, we have to stop carbimazole or methimazole for at least 5 days so that the production of the gland starts again and it starts to pick up the iodine. And it is at that time when we give radioactive iodine to basically treat toxic multinodular goiter. So again, toxic multinodular goiter is the next most common cause of hyperthyroidism. 20% of hyperthyroidism is actually toxic multinodular goiter. This is more common in elderly individuals, long-standing goiter, lumpy, bumpy thyroid gland, milder manifestations, mild elevation of FT4 and FT3, progresses slowly over time. Clinically, multiple firm nodules called plumber's disease and scintigraphy, which is thyroid technetium scan, shows hot and normal areas. So this is the thyroid technetium scan. You can see one nodule here. You can see a huge nodule here. You can see another nodule here, and probably a growing nodule here as well. So this is a toxic multinodular goiter. Remember, this is very different from Graves' disease, when you had both the lobes equally picking up the technetium scan. Toxic multinodular goiter has got blotches or nodules, hot nodules that are picking up the technetium. So this is after surgery. You see this lumpy, bumpy thyroid gland after surgery. Toxic single adenoma. So what does this mean? So toxic multinodular goiter means there are multiple hot nodules. Toxic single adenoma means there is only one nodule which is hot and which is making a lot of thyroid hormone and causing thyrotoxicosis. So thyroid toxic solitary adenoma is a single hyperfunctioning follicular thyroid adenoma, benign monoclonal tumor that usually is larger than 2.5 centimeters. It is the cause in 5% of patients. So again, 50% was Graves, 20% was toxic multinodular goiter, 5% is toxic solitary. Solitary means single. Toxic solitary adenoma, 5% is toxic solitary adenoma. Nuclear scan shows only a single hot nodule and TSH is suppressed, and the rest of the gland, because one nodule is making so much hormone, the rest of the gland gets suppressed. So again, this is, you see, this is the thyroid gland. In one of the lobes, you can see a huge nodule. Remember, it's usually more than 2.5 centimeters, but not always. And again, a toxic single adenoma. We've already seen this picture. It's toxic single adenoma in this picture, as you can see. So again, case history number 3. So we have now done Graves' disease. We have now done toxic multinodular goiter and toxic solitary adenoma. Case number 3, 28-year-old lady presented with 2 weeks history of fever, neck pain, palpitations, heat intolerance, and fatigue. Weight is 50 kg, blood pressure is normal, pulse is 120, tachycardic. She's febrile with 101 degree Fahrenheit temperature, diffuse grade 2 goiter, extremely tender on the slightest touch, moves with swallowing, no eye signs, mild tremors, FT4 is high, TSH is low, ESR is very high, 100, antibodies are negative. So what is this? Yes, the question for you people. But that is not the question that I've asked. I've asked which one of the following treatment options is appropriate for this patient. Now, you see, in this patient, there are a few things that point towards a certain cause of hyperthyroidism. You see, there is temperature, fever, there is neck pain, tender on the slightest touch. The neck is tender to touch. So there is fever, painful neck, tender neck, ESR is very high. Of course, there is hyperthyroidism. We see the symptoms. The signs in FT4 is high, TSH is low, but fever, neck pain, raised ESR, a combination of these three things points towards subacute thyroiditis, which is a viral infection. Which one of the following treatment options is appropriate for this patient? Propylthiouracil, carbimazole, radioactive iodine ablation, surgery, prednisolone. Yes, come on. Prednisolone. So we know that in this particular case, because it's a viral infection, you don't need antithyroid medications or radioactive iodine ablation. What you need is symptomatic treatment and anti-inflammatory agents. So you need beta blockers to control the symptomatology, and you need NSAIDs and especially prednisolone in a dose, in tapering doses of generally 4 to 6 weeks. So again, subacute thyroiditis is the next most common cause. 15% of your hyperthyroidism is subacute thyroiditis. T4 and T3 are extremely elevated. There is immune destruction of thyroid due to viral infection. So what happens is the viral infection destroys the thyroid gland. So whatever hormone is there gets released into the system. So there is a hyperthyroidism phase. And once all the hormone is released, this hyperthyroidism phase will eventually go into a hypothyroidism phase, and then eventually will come back to normal. So there is a hyperthyroidism phase, followed by a hypothyroidism phase, followed by normal gland in most patients, but some of them may remain hypothyroid. So destructive release of preformed thyroid hormone. Thyroid gland is painful and tender, that I told you. The nuclear scan, because it is just release of the hormone, there is no extra production. So nuclear scan shows no uptake in the gland, zero uptake. Treatment is NSAIDs and corticosteroids in tapering doses. So this is a normal thyroid gland. You can see two lobes of thyroid gland. And now just see this is just wiped out. This is neck. And you don't see any gland in the neck because it's not picking up any hormone, because it's being damaged by the inflammation, by the viral infection. These are the salivary glands here that you see, but you don't see any thyroid gland. So this is subacute thyroiditis. Coming up to case history number 4. Now, 24-year-old Gravida 1 with 10 weeks of gestation presented with severe nausea and vomiting of 2 weeks duration and had recently lost 5 kilograms in weight. Blood pressure is 165. She's tachycardic, excessive sweating and tremors of hands, small diffuse goiter, no bruit, no ophthalmopathy. Lab data, TSH is low, T4, the range is 4.5 to 12.5, but T4 here is 14.0. Again, thyroid antibodies is negative. So this is a pregnant lady, first trimester of pregnancy, nausea, vomiting, losing weight, tachycardic, excessive sweating, tremors. You see a low TSH, you see a T4 which is more than the normal range. What is going on? So what is the diagnosis? Graves' disease, subacute painless thyroiditis, gestational HCG-induced thyrotoxicosis, postpartum thyroiditis, toxic nodular goiter. Now remember, you cannot do a thyroid technetium scan or an iodine scan in pregnancy and lactation. We can't do that. So we don't have the liberty to do that. So again, most likely this is subacute, this is gestational HCG-induced thyrotoxicosis. Now, in this from 8th to 14th week, there is some sort of hyperthyroidism going on, of course. The baby needs more thyroid hormone. The HCG mimics the TSH and creates more hormones as well. So what happens is that the TSH will go low. In the first trimester, TSH is between 0.1 to 2.5. But in some women, TSH can go even below 0.1, and that can be normal. So how do we know that this TSH is normal? We check T4, and the T4 should be less than 1.5 times the range. So this is the range. So 1.5 times the range means somewhere 6.7 to 18.75 is the range according to this range. I multiplied the range by 1.5. 4.5 multiplied by 1.5 and 12.5 multiplied by 1.5. So the T4 can be more up to 1.5 times the normal range. So this is 14 and 1.5 here would be somewhere close to 18.7. So again, T4 is in the normal range with a low TSH. So again, you do not need to treat this hyperthyroidism in pregnancy because this is gestational HCG-induced thyrotoxicosis. So again, which one of the following treatment option is appropriate for this patient? We're talking about gestational HCG-induced thyrotoxicosis. Again, number one, hydration and propranolol, PTU, carbimazole, radioiodine ablation, surgery. Of course, because this is not true hyperthyroidism, and because this is just HCG-induced, we treat the symptoms of this thyrotoxicosis by hydration and propranolol. Because there is no excess production, we don't need a PTU or a carbimazole or a radioactive iodine ablation. Of course, in pregnancy, you don't need that. And of course, there is no need for surgery. Moving on to case history number 5. A 25-year-old woman is evaluated because of 3-week history of palpitation and increased sweating. She gave birth to a healthy baby 3 months ago and has taken a 6-month maternity leave. She's quite lucky to get that 6-month maternity leave. In fact, the patient intends to continue nursing her baby until she returns to work. So she wants to continue to breastfeed her baby. She has no history of thyroid disease. Pulse is 94, blood pressure is 90/70, thyroid gland slightly enlarged but not nodular. FT4 is high, TSH is low. Now this is a lady, just a short history of thyrotoxic symptoms like palpitation and sweating. Recently gave delivery to a baby 3 months ago, and the lab data shows that she has got hyperthyroidism. Now we need to ascertain the cause of this hyperthyroidism. So which one of the following treatment option is appropriate? So before we go on to the treatment option, what happens in the first 6 months after pregnancy? So again, she has thyrotoxicosis. Labs show clearly that she has got more thyroid hormone, and this is most likely postpartum thyroiditis. And again, remember, you do not have the liberty of doing a thyroid technetium scan or an iodine scan if a lady is pregnant or lactating. So again, this is postpartum thyroiditis. And again, the treatment option is propranolol. So again, symptomatic treatment, just like subacute thyroiditis. Remember, in subacute thyroiditis, which was a viral infection, we gave propranolol, we gave hydration, and we gave NSAIDs and steroids. In postpartum thyroiditis, we basically just give propranolol and maybe excess hydration. Coming up to the next case, the last 2 cases are very interesting, so be with me. A 34-year-old man, now this is a very interesting case. A 34-year-old man is referred by Karachi Psychiatric Hospital for fluctuating testosterone levels, sexual weakness, and feeling of fear. He has normal sense of smell, no weight loss or gain recently. Blood pressure is 125/80, pulse is 100 per minute. weight is 62 kg, head and neck, lack of facial hair, thyroid is not palpable, no gynecomastia as well, axillary hair is just stage 2, 3, which is of course less, genital exam, phallus is normal, adult phallus, pubic hair is stage 4, scrotum is small for age, testis, right is 6 ml, left is 8 ml. Remember, in this age, it has to be more than 15 ml. Again, prolactin is 6.5, which is normal. If you see the testosterone here, it is 21 only. It should be between 300 and 1400, but a very low testosterone. So with a low testosterone, you expect high LH, FSH, but LH is low, FSH is normal. So with a low testosterone, LH, FSH are not rising. So this FSH is basically, you can say, inappropriately normal, and LH is of course low. Fasting blood sugar is 89, which is normal. FT4 is high. TSH is also high. ACTH is not detected, and cortisol is just less than 0.4. So what is happening is this person is hypogonadism. Testosterone is low. LH, FSH are also low or inappropriately normal. So if testosterone, which is produced from testis, becomes low, then LH, FSH should rise. But there is some problem with the pituitary, I think. The testosterone is low, but LH, FSH is also low. So with a low testosterone and high LH, FSH, you understand that the problem lies in testis level. But with a low testosterone and a low LH, FSH, the problem lies probably in the pituitary gland. Again, you see that there is low cortisol and the ACTH, which comes from pituitary, is not high. ACTH is also low. So if there is problem with the adrenal gland, if cortisol is low, ACTH should be high. But if there is problem with the pituitary gland, if cortisol is low, ACTH is also low. This means that ACTH is low and subsequently cortisol is also low. Again, in this patient, you see FT4 is high, TSH should be low. But FT4 is high and TSH is also high, which means that this high TSH might be leading to high FT4. So we understand that there is problem in the pituitary gland, there is hypogonadism, there is low cortisol levels, and there is high FT4 and TSH. Oh, probably I told the diagnosis early. Which one of the following is the most appropriate diagnosis for this patient? Graves' disease, TSH producing pituitary adenoma, Kalman syndrome causing hypogonadism, Klinefelter syndrome, Addison's disease. So of course, this is not Graves' disease. FT4 should be high, TSH should be low. I mean, that's not the case here. TSH producing pituitary adenoma, most likely yes, because FT4 is high, TSH is high, and this TSHoma, which is a very, very rare tumor, this tumor is causing other pituitary cells to function less, to constrict, to get hypoplastic or dead, and not produce enough ACTH. That's why ACTH and cortisol is low, and also low LH and low testosterone as well. So again, this is a TSHoma, which is also causing hypogonadism and hypocortisolism because of the tumor's mass effect in the pituitary gland. This is the last case for the day. This is case number 7. So a 42-year-old woman is seen in ER with sinus tachycardia. She is massively obese, but has lost 14 kg in the past 3 months. Blood pressure is 145/70, pulse is 120. She has stare, but no proptosis. Her thyroid is not palpable. Marked obesity makes examination difficult. Tremors are present, and she has decreased muscle strength. Her FT4 is high, TSH is low, 24-hour radioactive iodine uptake is very low. Or if you do a thyroid technetium scan, the uptake comes low. Thyroglobulin, now the uptake used to come low in which condition? Subacute thyroiditis. So thyroglobulin is 0.5. Remember, thyroglobulin is basically whenever thyroxine is produced, you get thyroglobulin as well. So if thyroxine is high, thyroglobulin should be high. But in this case, thyroxine is high, thyroglobulin is low. So if this thyroxine is coming from inside the human body, if thyroxine is high, thyroglobulin should be high. That's not the case. Thyroxine is high, thyroglobulin is low. So what's going on? So again, if you see what is the diagnosis, subacute thyroiditis or struma ovariae, silent lymphocytic thyroiditis, thyrotoxicosis factitia, exogenous thyrotoxicosis, or recent iodide exposure. So again, you see that this patient has more thyroxine in the body, more FT4, less TSH, but then thyroglobulin is low, which means that this thyroid hormone production is not inside the human body. This thyroid hormone is coming from outside, and then the inside thyroid hormone production is low. As a result, the thyroglobulin is low. So again, this is thyrotoxicosis factitia, exogenous thyrotoxicosis, where people used to abuse thyroid hormone to reduce weight. And same seems to be the case in this 42-year-old obese lady. So again, just reviewing what we have studied, age and gender, Graves' disease, mostly in 20 to 40 years age group, toxic multinodular goiter, usually in the elderly, more than 50 years of age group, toxic single adenoma, 35 to 50 years age group, and subacute thyroiditis can come at any age. If we see the male to female ratio, Graves' disease is 5 to 10 times more common in females, and toxic multinodular goiter 2 to 4 times more common in females. Now, just a revision of the Technetium scan. This is a normal scan. This is diffuse uptake, diffuse increased uptake in both glands, Graves' disease. You can see multiple nodules here, multiple hot nodules. This is toxic multinodular goiter. And here you can see one single adenoma, one single toxic nodule. So this is toxic solitary nodule. So clinical features, those that occur with any type of thyrotoxicosis, then there are certain symptoms that are specific to Graves' disease and some non-specific changes of hypermetabolism. Common symptoms of hyperthyroidism are nervousness, anxiety, increased perspiration, heat intolerance, tremor, hyperactivity, palpitation, weight loss, despite having an increased appetite, and reduction in the menstrual flow or oligomenorrhea. Symptoms specific to Graves' disease, diffuse, painless, and firm enlargement of thyroid gland. There is a bruit that is audible, remember, with the bell of the stethoscope, and you have to hold the inspiration, hold the patient's breath at inspiration to actually listen to that bruit with the bell of the stethoscope. And don't forget to tell the patient to breathe again. Ophthalmopathy, eye manifestations in 50% of cases of Graves' disease, and dermoacropathy, skin and limb manifestations in 20% of cases. Now here you see the proptosis. You can see the lid retraction in both these pictures. Usually you don't see these upper sclera, in normal people you don't see upper sclera. But in lid retraction and proptosis and lid retraction, you see the upper sclera very clearly. So again, you can see the periorbital edema and chemosis. You can see the periorbital edema, and you can also see the chemosis. This is severe exophthalmia in Graves' disease. These are signs of Graves' disease. You can see thyroid dermopathy. You can appreciate thyroid dermopathy in this picture. It's very interesting to go back home and read about thyroid dermopathy. And this is thyroid acropathy, which has got clubbing and osteoarthropathy. This is onycholysis. So again, when you diagnose, you see the typical clinical presentation. You see a TSH which is low. You see elevated FT4 and FT3, thyroid antibodies, especially in Graves' disease. You can do ECG to see cardiac manifestations. And remember, a nuclear scintigraphy, a thyroid technetium scan, or radioiodine scan In Pakistan, we usually do thyroid technetium scan. Remember, there is no role of an ultrasound neck in diagnosis and management of hyperthyroidism until there is a cold nodule also sitting somewhere in the thyroid. Treatment options: symptom relief medications like beta blockers, anti-thyroid medications. We've already discussed that: methimazole, carbimazole, and then propylthiouracil. And then radioactive iodine treatment, as we discussed, is the treatment of choice in toxic multinodular goiter and toxic solitary adenoma. Thyroidectomy, rarely used, usually where there is a huge gland. NSAIDs and corticosteroids for subacute thyroiditis, as already we have discussed. So symptom relief, rehydration, beta blockers, rate-limiting calcium channel blockers. If beta blockers are contraindicated, always ask about asthma if you are prescribing beta blockers. And then if there are any cardiac arrhythmias or heart failure, you need cardiology opinion and treatment for that as well. So how long to give anti-thyroid drugs? So reduction of thyroid hormones takes 2 to 8 weeks. So again, when we've started somebody on anti-thyroid medication, we need to check FT4, FT3, and sometimes you can also check TSH. But remember, more frequently, you need to check FT4 and FT3 every 4 to 6 weeks. TSH takes 3 months to resolve, and FT4, FT3 basically gives you an idea of the last 10 to 14 days. In Graves, many go into remission after 12 to 18 months. I told you 50% of the patients will go into remission in 18 months if they have been treated well and they have been compliant. But remember, 40% of these will have a relapse in the next 1 year. Now, in such patients who go into remission, anti-thyroid drugs may be discontinued, but patient needs to be followed up. As I already told you, 40%, they have a recurrence in 1 year time. And again, multinodular goiter and toxic adenoma, you may give anti-thyroid medications to control the toxic symptoms. But again, once they are close to being euthyroid, there has to be treatment with radioactive iodine. And if there is a huge goiter, which is causing tracheal pressure, as well as dysphagia, surgery is an answer to that. So again, radioactive iodine in women who are not pregnant. Remember, never give radioactive iodine in women who are pregnant and lactating. And somebody who gets a radioactive iodine treatment, women cannot get pregnant for the next 6 months. So you do need to counsel that as well. In cases of toxic multinodular goiter, Graves' disease, toxic solitary adenoma. Graves' disease, there is a debate between medications versus RAI treatment. Graves' disease not remitting with anti-thyroid drugs, yes, you use radioactive iodine. The effect is less rapid than anti-thyroid drugs or thyroidectomy. When we give radioactive iodine, the first effect that comes in is after 2 months. And the effect comes from 2 months to 6 months. That is why whenever we give radioactive iodine, we continue with anti-thyroid medications for the next 2 months, because the first effect of the iodine treatment will come after 2 months. Radioactive iodine is effective, safe, and does not require hospitalization. It's done as an outpatient dosing, orally as a single dose, in a capsule or a glass of juice or water. Very few adverse effects as well. So radioactive iodine are different types. There is iodine 123, iodine 131, or technetium 99. They are used to scan for a nuclear scintigraphy. But for treatment, you use iodine 131. Surgical treatment is needed with severe hyperthyroidism in children, pregnant women who cannot tolerate ATD, anti-thyroid drugs, and are very symptomatic. Remember, in pregnancy, whenever you operate, second trimester is the best trimester to operate. Large goiters with severe ophthalmopathy, large multinodular goiter with pressure symptoms, those who require quick normalization of thyroid function should also be offered surgery. Thank you very much. It was a pleasure to be part of this Pakistan Endocrine Society thyroid course. Hope you enjoy rest of your lectures. Have a good day. Thank you very much. Allah Hafiz.